Hey everybody, welcome back to Dental Unfiltered. I'm Matt Brown, your normal host, and we have an awesome guest today. She goes by the name Extraction Jackson. It's Dr. Julia Jackson. We met at a speaking competition at Midwinter or Yankee. It was one of the two. It was Dentistry's Got Talent, and she stood out for me and instantly connected with her. I liked her a lot. We stayed in touch. Julia is an oral surgeon. She owns and runs an organization, the International Implant Institute. She's an instructor. She's an amazing, talented oral surgeon, and she teaches GPs. And her community of oral surgery has actually outright accused her of being a traitor. And there is a gang warfare, territorial mentality in dentistry of like, we're OS and you shouldn't be doing this. And then I think that her crossing the line and becoming part of the overall greater community kind of is a credit to her character of let's help everybody and do a better job. So we're going to talk with Julia here in a minute. We're going to talk a little bit about her point of view from having an implant practice to the business of she's seen of an implant practice out to the exit of an implant practice. And she is a subject matter expert in a wide areas that go towards implant surgery, surgical things, and practice involving that. And her platform, International Implant Institute, is pretty awesome. And like I said, I couldn't wait to have her on the show. So Dr. Jackson, why don't you tell us a little bit about yourself, and then I'll get into asking some awesome questions.
Thank you, Matt. I'm so happy to be here. It's a pleasure to have an opportunity to be on your show. What you forgot to mention is that, yes, we met in Boston, and yes, we met at the Dentistry Has Talent activity. But what you forgot to mention is that you won the actual activity, and I just clapped in the audience.
I took third.
That's a winner, third. Matt. That's
a
placement on the scale.
Yeah, I took third overall, but it was a fun event. So
yes, I am very excited to be here because Matt has opened my eyes at how perhaps oral and maxillofacial surgeons in the past have been a little less enthusiastic, but I am super enthusiastic. I love taking out teeth. It took a long time for me to become an oral and maxillofacial surgeon. It was an additional 6 years of clinical and surgical training after dental school, 2 years in Brooklyn, New York, and an additional 4 years in Washington, D.C. And then I've been in private practice for the last 15. And, you couldn't drag me away from oral surgery. It's embedded in me. They don't call me Extraction Jackson for nothing, Matt.
Maybe I never asked you this question. Are you in the chair practicing currently?
I have been practicing since 2011 when I finished my program. I did about 2 or 3 years in Philadelphia. I'm from Philadelphia. And then for all the ladies that are listening, finally a guy asked me to marry him. And after all this education and completely engrossed in studies and bombarded by exams and tests and never seeing the light of day, he asked me and I said yes. The caveat was that he didn't want to live in Philadelphia, which is my home state, my hometown. And he said that we wanted to move to D.C. I said, oh, my goodness. So make a long story short, I schlepped all my surgical tools, all my instruments, implants, bone grafts, and I started private practice in Virginia, Northern Virginia. Originally a DSO, Matt, which is a really different perspective than actually opening a brick and mortar. I've never actually
oral surgeon
owned
in a DSO.
Own. Right.
I don't think I've ever talked to an oral surgeon in a DSO.
Hello, Matt. It's me.
Yeah, that's
and
new.
So we had 3 oral surgery practices. So I was the only one who went around to all 3 locations. There was a total of 4 of us in the group. And so that was a really nice perspective. You come in, you do what you have to do. You treat everyone the way they should be treated, like family. And then you go home. I didn't have to worry about the light bulbs or who was going to pay for maternity leave for the lady at the front desk. None of that kind of extra parts to the business of dentistry. But I got a chance to really see how does it work and what are some of the guidelines for best practices. So after 10 years here in Virginia, I started International Implant Institute, a continuing education program to teach general dentists how to do the surgical procedures that I've been doing. And yes, you're right, Matt. They did call me a traitor. My oral surgery colleagues, they say, how could you be teaching general dentists how to do implants? I said, folks, number one, they're already doing them. And why don't we help them and
Cat's
show
out of the
them
bag, man.
to do best.
Pandora's box got opened, bro.
Exactly.
It's
And
happening.
number two, there are some that really want to excel. And probably if I didn't become an oral surgeon, would have been one of those who wanted to do all on four cases as a GP. So I might as well hold their hands and make sure that they have systematic systems in place so that they can be effective, efficient, and high producers. So, they call me a traitor, whatever. I can teach anyone how to take teeth out. It's not really that tricky, Matt. It's a little finesse, but. And so the Institute has come a long way, and we've been doing really wonderful things. We have some courses coming up I can't wait to tell you about, and lots of different opportunities for general dentists to broaden their perspectives.
Yeah, I'm really excited to have you on. So really quick, what was your feelings like the first time an OS told you were being a traitor? Like, did you just I don't care?
Well, it was a conference. And it was a room full of oral surgeons, and I was letting them know about our institute, to let them know that we're teaching general dentists. And more importantly, I was offering them the opportunity to be faculty, because some oral surgeons love to go with us to Cancun, Mexico, to teach general dentists how to do the procedures. What's better faculty than other oral surgeons? But there was one in particular who just really couldn't change the way he thinks and was saying, why would you want to teach them? And what I thought was really strange about his statement is that he was a residency faculty. He teaches oral surgeons oral surgery. So he's an oral surgery attending. And so he does have in his heart to be a teacher. He does have in his heart to teach oral surgeons, but it's off the grid to teach general dentists. And I thought, no, we need to open this up because they're already hungry. So let's make sure that they're not unable to be successful.
It's accelerating. And I think part of it where it's narrow-minded, we're getting to the business part of this here in a second, is, let's say I was an oral surgeon in Charlotte. And like I said, anything I say you think is crazy, just correct me. Let's say I was an oral surgeon in Charlotte, right? We know that the GPs are going to start doing implants, right? So why would we not have a relationship and teach them? So when they hit the cases they're just not comfortable with, we guarantee they come to us. Or that they know what they shouldn't do to protect the patient, right? There's a knowledge here of it's better for everybody that the OS being open-minded to teach the GPs, because it's better for the patient, better for the GP, better for the OS. The guy's a narrow-minded turd for not thinking about it that way. I don't know how you don't see the greater picture of expanding knowledge is always better for all people all the time.
So it really kind of burns them up a little bit when I remind them that it's general dentists that place implants first. It's not as if it was oral surgeons. Brandon Mark was working with orthopedic surgeons to understand how bone integrates with titanium. So this was a general dentist activity, which oral surgery took over when in wartime, utilizing plates and screws for when we had broken bones and mandibles. But then to start to think about how to replace teeth, we brought on titanium screws, external fixators, internal fixators, intraosseous bone grafting materials. So, this is not new to general dentists any more than it's new to oral and maxillofacial surgeons. So I really just tickle and think, why would you be so narrow-minded? I don't call him a turd, but like you do. I say, why would you be so narrow-minded that this is not a field of dentistry that we can all really jump right into and explore?
It's an exciting modality of treatment.
Absolutely.
And I will say this too. I think the most technology investment over the last 5 years or maybe 10 has been in this modality of treatment. Intraoral scanners, full digital workflow, 3D printers for guides, mills. I think I would say a large portion of the new technology coming into practices, I would say the majority of the money invested in developing that has been in this exact modality of treatment. People went from labs to technology rooms, right? What's that been? People went from no CBCT to a CBCT. What we just said is a couple hundred to a few $100,000 worth of equipment that didn't exist. That's how exciting this modality is. It's like Star Trek. I scan your mouth, I send the file over there, and here's your new mouth. What's cooler than that?
And Matt, the wave is still going. There's the wave for zygomatic implant placement that none of us were taught in school. So there's a whole, let's just say, generation of people that need to know how to place zygomatic implants, but we don't have the teachers to teach us, and we don't know that much about the technology in front of us. So we're kind of sitting in the middle trying to figure out, well, how do we learn on our own so that we can continue to treat patients that have atrophic maxilla? We have to be able to make sure that we can still put implants in for people who don't have enough bone. And we don't have the education because it wasn't talked about when we were in dental school. So there's, or even in surgery, quite frankly. So what I'm talking about is like 2019, 2018, 2017. We hadn't peaked for zygomatic implant placement yet.
Zygos and pterygoids and stuff is a place I've been doing a lot of reading. Because me and you talked before about this, and I have a point of view that I feel like there's a lot of all-on-fours being done, and maybe more than should be, in my opinion. And then I was thinking down the road, like, so if this stuff goes bad and they still want to have it, what has to happen? Well, you got to do zygos into the cheekbone, right? And then I started doing more research about why they fail and the flag pulling and how they can move based on the torque, I guess. I'm not you guys, right? And I started thinking, like, well, how many people can really do this? And I have one doc in my stable who's out in the Dakotas, who's got 4 practices with me. I know he can do them. And I have an OS here in town that I've talked to. His exact wording to me, we're on a fishing trip together. He goes, Matt, I can do them. I'm not doing them. And I'm like, really? And he's like, Matt, I'm just not. He's like, I'm not going into the cheekbone. I'm not doing it. So it's a brave new world. I think we're in a weird place right now where there's this whole digital frontier opening. And I feel like the digital frontier is opening up for GPs to do more than ever. And I think OSs in some ways can take on kind of a role of like, I'm like a regional clinical director if I have a good relationship with all these GPs, and then they trust me and I help them when they get a little bit of trouble, and then when they get to something they can't do at all, I get it. Like if I was in like a Charlotte, North Carolina, or like a Charleston, I would be hanging out with every GP and being like, yo, bro, I'll teach you how to do that. Let's figure it out, man. I'll come over and do it with you. You want to figure that out? Oh, this we can't do here. Send that over to me. Like, think about it. You could become a little regional mini clinical director and you could have a ton of business.
So I have that going on, Matt. My month of June is booked as chairside concierge surgeon. So I will go to general dentist offices and help them place implants all month of June. And, I can show you my calendar. So, we'll go over the treatment plan. We'll go over the CT scan. We'll make sure that they have the set that they need. Make sure that the patient has taken care of all finances. Make sure that they know exactly how this is going to happen. Perhaps it's going to be a guided case. Make sure we have our guides then ready to go. And then I'll go in and sit chairside. Just encourage them. Make sure you have profound anesthesia. Make sure you lay your flap more appropriately on the crest so that it's not too buccal, not too lingual. I don't want to get too technical, but I want to make sure that they don't have to close their sutures over top of the implants. We want it over healthy bone, if that makes sense. So I can't wait this summer, June, chairside concierge service. And also, Matt, we started a study club, just like you're thinking. It's called the First Ladies of Dentistry Study Club. It's a Facebook study club for general dentists that are women in dentistry.
There's not enough resources for women in dentistry. There's a group I can connect you to it's called DOM, I think, Dental Entrepreneur Women. There's a group I can connect you to. There is not enough resources for women in dentistry.
No, it's not. So our group, the First Ladies of Dentistry, is for women that own their own practice or are associates and want kind of that nurturing or hand-holding, good referral base, excellent networking. We love to talk about the business of dentistry, Matt, how to start your practice, how to get your practice thriving and running. And also, it's never too late to plan for retirement. So we talk about the whole gambit of the business of dentistry and just generally making people feel empowered and encouraged that they can place implants as well.
There's a Women of Dentistry group. I will find it for you. I'm looking for it right now to plug it on the show. I met them. Oh, Dental Entrepreneur Women is what it is.
Do.
Yeah, do. Okay, so do. I spent time with some do leadership.
Ann Duffy is terrific. I spent some time last week.
I spent some time with them in Atlanta. Do, if you're a female dental professional, you do anything in dental, you have a company that supports dental, whatever it is, it's a mistake if you don't have a membership with Do. And the Do magazine is great. I spent some time on this. Anyway, let's get into the business part of this. So, you went to talk a little bit. So Dental Implant, the International Implant Institute obviously has a clinical side. But what's unique is a lot of the clinical CE groups don't have a business side. They're very clinically focused, is what I have found, right? And it seems like from us talking, you do have a suite of like fundamental ideologies for the business side of it, start, middle, end. We talked a little bit before the show started about retirement and exit. And me and you talked, and I said, I build every company I own based on an exit strategy from day one of a date and everything and a target. And I feel like dentists wake up and they're 45 years old and like, hey, my buddy just sold and retired. I got to get on this thing. And then they call a broker like McLaren Associates or one of them. And they're like, I want to sell this year. And they're like, well, we should have talked about this 3 years ago. So I find that's a really common occurrence. So this is the subject you wanted to talk about. So what made you want to have a business component to the International Implant Institute? Because it's very unusual to me, at least, that's included in a clinical product.
I think really the way that it budded was because if we're talking about high yield procedures such as implant placement, bone grafts, membranes, which can be very nice procedures to augment and to complement your regular treatment plan. For instance, if I take out a tooth for $84 and then you take out a tooth for $84 and you put a membrane for $1,000 and you graft it for $1,000, now you took out a $2,084 tooth. That's very much of a helpful procedure for your bottom line. But more importantly, you need to convey that to the patient that this is going to allow for future implant placement. They can't think that far ahead. They just want the tooth out. So if we set the stage for them to get an implant in the future, even if they're not getting one immediately, at least we've grafted the site for future implant placement. It's production for our business, and it's set the patient up for predictable results. So we know that bone grafting is absolutely a positive, a win-win for everyone. And so if we're thinking about how can we incorporate high yield procedures, well, that would be how to grow your business, how to make sure that your dental practice is lucrative and productive. Well, I always say it's never too late to plan for retirement. So if we have the middle part, and I may have brushed over the beginning part of how do you get your contract negotiations, how do you make sure that you understand what your DSO is making you agree to, what's your on-call schedule, the beginning parts, how do you figure out commercial real estate agent, how do you make sure that you can get a small business loan. So that's like the beginning. The middle was how to make the money, and the end was, okay, what's your exit strategy? So I think when we're talking to clinicians, such as dentists, we need to make sure that they don't forget the business part of dentistry. It really just all started to blossom together when we started to see how important it was for them to understand how to manage their money and to make good decisions on how to be productive, if that makes sense.
You mentioned commercial real estate person for dentists. Do you have one that you like? Because I have one that's really good.
I definitely have one. What's your guy's name, Matt?
I've worked on several startup projects, like hundreds he's been involved in. His name's Robert Montgomery. And if you have someone that's great, but Rob Montgomery speaks almost everywhere I speak. The guy is, from what I understand, the commercial dentistry guy. But if you have one that's good for you and your students use them, if you'd like an intro to Rob Montgomery, I can make it. Rob, I've probably done hundreds of startups that Rob has done.
More arrows in my bevy. No problem.
I'll introduce you to Robert Montgomery. He's a good dude. So what's really interesting is you're kind of looking at business from a clinical point of view of how to set up the patient better for success clinically and, modality treatment wise, but also what's best for your practice. And I find that docs kind of have a tunnel vision of that one thing they're working on in the mouth. And I feel like they're not looking forward. And there's things that I've discovered, right? And I always say, I'm not you guys, right? But as a third party looking in from a different point of view, and some docs do what I'm going to say and some don't. And some, when I explain it to them, it's like revolutionary. And other docs yeah, I've been doing it for years. And I find that that's the thing in dentistry. There's these pockets that do things one way and pockets that have never heard of it. And one thing is, a lot of my docs that do snap-in dentures, they'll do a regular denture and they'll put a bar or mesh in to reinforce it for snap-ins later. And just like you're talking about setting up the membrane and stuff for later for the best result, every time they do a denture, they say, hey, denture life sucks. And because I care about you, I reinforced your denture so that way if you want to do snap-ins later, we're ready. And if they do 10 dentures, maybe 2 come back in the next 2 years, right? But it's kind of the same thinking you're talking about of like, are we doing this foundational thing to set up the patient for the unknown success that could happen in the future? I think some docs say, well, they're probably not going to do that. Well, why don't we just pave the road so if they make a decision change, we're ready for them?
Exactly, Matt. Why can't we set up and think past I have my own little saying, I call it thinking outside the socket. Like, really.
Oh, that's cool. I'm stealing that. I'll give
No,
you credit for it. I'll give you credit.
It, Matt.
Julia,
No.
I'll give you credit for it, though. I've stole stuff from Kelly Schwartz. I say, Kelly Schwartz said this. I'll say Julia Jackson said it.
Thinking outside the socket, Matt. I mean, legitimately. And bear with me. Here it goes. So, as a clinician, we think about these 2 little spaces, the interradicular bone between the 2 roots. Like Tom Brady, that's our target. You have to hit the bone between the 2 roots so that you can establish your initial stability and your pilot hole for your implant drill. And then you drill down more apically so that you can have more native bone. My point is, Matt, you can't be focused on this little tiny spot. You have to think outside the socket, past the gums, out of the mouth, bring your head up, and realize, folks, that as dentists, you are business people. You are business person, businessman, businesswoman. You cannot be focused, so tiny tunnel vision that you only thinking about how you're going to, have a restoration or fix a cracked tooth. You have to think about what kind of money you need to save now so that you do not have to be fixing cracked tooth when you are 47 years old. So the idea, Matt, is that they need to think outside the socket. Don't take my statement, Matt. I see you. You're looking hungry over there.
So one thing I tell all my guests or any subject matter expert I work with is if I reference anything you taught me or I learned, I always try to make sure I give you credit for it when I say or do it. Now, if you want me to use that, I won't use it.
You
but
can use
if there's anything I learned from you, I will do my best I can to reference it came from you. So people do get tunnel vision on that thing. And I feel like part of the reason why that becomes very easy to happen is one, your overall foundational training in school is clinically 90%, right? It's focused, right? But then I think also docs tend to naturally be people that would be clinically focused, very engineer minded. I think one flaw is, and I think you said this, but you didn't say it the way I'm going to phrase it, and you're welcome to steal this. I think a lot of docs I work with think from where they are out into the future. They think about they look at it like going down the road instead of what I like, and this comes from my experience working as an enabler in the special operations community and working with the best warriors in the world, is you should plan backwards from the objective, right? So it's called it's in the special operations world, Julie, it's called planning backwards from the X, because the X is your target, right? So let's say the target for the patient eventually was that we clinically believe they should have an implant. So what you're saying is, well, I know that's the destination that I would like for the patient. Whether they do it or not is one thing, but that's the destination I hope they get to. That's their X. So you think backwards, okay, well, I want to do this membrane and do this grafting and have it ready. And I think the planning backwards from the X in dental doesn't happen on a business level, doesn't happen on a practice management level, doesn't happen on a procedure level. It's not a common way of thinking. And I think from talking to you in the time we've spent together, I think that's a natural way of thinking for you.
Absolutely. And here's another one for you. Prosthetically driven implant placement. You have to remember where's the tooth so that you can remember where to put the implant so that you can know that the crown will fit appropriately with the other teeth. Exactly. It's the same idea. Prosthetically driven implant placement. Or another way we think of it is reverse engineering. You have to think about where you're going to figure out how you get there.
And it's funny, like I always say, I'm not a clinician, but I talk to a lot of you guys, and I find GPs say stuff like this. Well, the OS I work with doesn't place from a restorative point of view.
Really?
I have GPs that say that. Okay, so I'm not a GP. I'm not you guys, but I've had GPs that say that. Do you think that's just rhetoric, or do you think that's common in the OS community that I don't think about it from restorative?
No. Absolutely, because oral surgeons place implants where there's bone. So we get the CT scan and we look and we see, oh, there's a whole lot of bone. We're going to put the implant there. And they forgot that there's going to be this general dentist who's going to receive this implant and not have any tooth underneath where they decided to put the implant. So if you don't have a tooth underneath, then did you really need the implant if you're not going to be able to restore the implant? You can't restore it if there's nothing to occlude with it. So absolutely, yes, there are oral surgeons, my colleagues and friends, who could think that they are going to put the implant where there's bone. And what we want to change the thought process to be prosthetically driven implant placement, which means we want to remember where is the tooth going to lie so we can decide where to put the root.
Yeah, it's reverse. Like I said, it's reverse engineering. It's planning backwards from the X, and it is. I think it's a training problem. I think it's an education problem. I think that this is the kind of thinking that needs to be taught in school. I think dental professionals need business training. Like it amazes me you guys don't get a fundamental accounting class, a fundamental management class.
Come to our classes. That's what we have. We have a plethora, a library of business courses, an entire curriculum for prosthetically driven implant placement. We're going to Cancun so we can place implants on live patients July 15 through 17. We have a course next week, how to discuss postoperative analgesic pain, Exparil, and Dr. Dan Fenton. We are cutting edge continuing education program for general dentists so that they can think outside the socket and make progress. We have online courses, Matt. We have in-person courses. What can I say? We can't rely on dental school. We've been out too long.
I think dental school in general has some very flawed culture that I've been pretty vocal about. And one thing that I hate that gets said is, do quality and the speed will come. What does that mean? Like what is like, there's obviously best practices. Like if I came to you for a course and you said step 1 through step 9 gets you there, when that creates quality. Well, if I just work on step 1 through step 9 and find my groove, my speed will come. But a lot of times there's like no direction in it. Like you do it your way. What's best in your hands? It gets said a lot too. Do what's best in your hands. No, there's people that have done this a ton, like the Julia Extraction Jacksons of the world that have figured out what gets the best outcome. When we're in my world of special operations, we don't say, use the gun how you want. We'll figure it out. It'll come, buddy. No, it won't. There's lives on the line. It won't come. We've done thousands of missions, and this is how we do it. There are docs out there like you who have done thousands of reps. It shouldn't be what's best in your hands and it will come. It should be, here's the structure. I think that's like, I don't know. I don't like the culture of dental schools. I meet these D4s that come out of school and these new associates, and they tell me about school, and I'm like, what other program in the world is so incomplete?
Exactly. What a way to put it. That's exactly right.
What other multi-$100,000 education do you come out with a puzzle to put together yourself your first year?
What's the business of dentistry?
Yeah, like it's like you come out of school and it's like, I'm sorry, these brand new associates that were D4s, especially post-COVID, because a lot of things changed in schools during COVID, and they're like, we're not going to change it back. This is better for the school. I think this is totally off subject we're talking about. I think dental schools are more loyal to themselves than they are the students. That's just my opinion. If you look at the loyalty of the student, you should have way different courses.
I think that the dentistry has evolved from this idea of it's just a tooth and, we just need a filling to, okay, well, actually, the more people you treat, the more production you can make. And so we never really get into the business part of dentistry whatsoever. We're still trying to make sure that we understand the anatomy of each tooth. And there should be some additional curriculum added to dental schools that encompass how to run the practice. That part hasn't come yet. We're barely on the how to do taxes as a dentist. How do you make sure that you have some type of real estate understanding as a dentist? There's too many parts as a dentist that dental school is not covering. At this point, there's dental schools that are made from DSOs so that they're not even funneling people into becoming in private practice to know how do you pick an office that's not on the second floor when you're planning on sedating patients. Can you imagine that, Matt? They would actually get a practice on the second floor? How are you going to have the patient walk down 2 flights of steps if you sedated them? So that's not the practice you want. You know what I mean? They're not helping them make sure that they understand what's the best things or best thought processes to have for the business of dentistry.
I have PTSD from the military, and I do ketamine therapy, and I don't care who knows. Psychedelics have done wonders for my psyche and my emotional issues from my time. And I went to my first ketamine clinic I ever went to, which is not the current one I go to now. So if my current ketamine doc listens, because she does from time to time, I'm not talking about you. You're awesome, okay? My first one I ever went to, he was awesome too. I had to walk down steps after ketamine therapy, and I have one leg. And it was only like a little bit of steps, but I looked at it like it was Mount Everest, and I'm like, I got one leg, bro, and I'm not all there right now, and you want me to walk down this? And I was looking, and I was like, did anyone think about this part of this? No, and you're right. Like, there's things like that aren't thought about. And it's even like you brought up sedation. Like, GPs now are doing more sedation than before. This is getting off subject too. I put a lot of my brain to sedation too, learning about it, because it goes hand in hand with the stuff we're talking about. And I think oral conscious scares me more than IV, because IV, you're right there, you're controlled, you can just turn it off, and you have life-saving equipment. Oral conscious, I've read some stuff. I don't know if you've read any of this, where certain foods can accelerate metabolization, and the drugs can metabolize differently, and the patient could get hit harder once they get home based on stomach and some other stuff. But sedation's happening more and more, and I think it is good because it's a better experience for doc. Doc can do more work quicker and easier and higher quality, and the patient has a better experience. I think all these new modalities, and I think GPs breaking into these things, I think there needs to be more people like you of a higher education level with more reps who are willing to cross the line and say, I want to become part of the GP community and invest in you this way.
Can I tell you one more, Matt? Please let me
go for it. Yeah, we have a little bit of time. Go for it, Julia.
So I have this plan in my mind that one of these days we can have public health facilities that provide dental services. And those general dentists should know how to place implants. When an elderly person or a person that has low income or a veteran comes to a public health facility, they should not leave with a teeth that come in and out to put by their bedside. We should be teaching all general dentists that work in public health facilities to be able to place at least two implants on the mandible so that the denture can snap in. It should be regular activities in public health facilities.
It should be the fundamental standard of care.
Absolutely.
It should be snaps.
And the reason we're not doing it is because the general dentists that work in public health facilities don't know how to place implants. I want to teach all of them. Every public health facility should be able to place implants. I'm not the one to say how you're going to get the implants into the public health facility with a cost, because if it's public health, maybe they paid $50 to get in there. But I'm saying that as a standard, as a human being, at this point in 2026, if they walk in and they're missing all their teeth and the denture doesn't fit, they should be able to get 2 implants and leave with implants that are placed by general dentists. It shouldn't take, specialists to be able to fix the general public in public health with 2 implants.
We're going to wrap up with this. I'm watching the data on implants across the country. I share a lot of data with Dental Intelligence. We book 30,000 dental appointments a month at Energize, and all of our clients have DI, and I get to see all this data. The cost of implants is coming down in certain markets in the country. There are markets in the country where from placement to crown, it's $3,500 now. I believe that there's a point in time coming where implant is going to be culturally like big crown. It's not going to replace crowns, because obviously there's teeth that need to be restored, not pulled for an implant, right? But I'm talking about the level of procedure. It's going to become that common.
It should be.
I think it's going to be. I think it's coming. I think implants right now are a little bit of a bubble. There's a lot of money being invested in it. There's a lot of it being done, and I feel like there's a price being held, but I feel it shrinking. and I think it's gonna pop around $2,500. And I don't know if that's 5 years from now or 10 years from now, but I have a feeling it's gonna get there because of the cost of the implant and the cost of the crown. There's a little bit of margin there, and docs, and I'm not you, docs. I know docs that say they can do it in like 45 minutes or less placement, or an hour maybe. Does that sound right? It's a pretty easy procedure. So I have a
Absolutely.
feeling docs say I charge $5,500 for an implant. Then you look at their procedures and they do three, and they get the patient to say yes to three for 9,000, and they do it. I rarely find in their system the price they say they do it for, and I'm so talented, actually ends up being the price they're doing it for. Does that make sense? Like the actual, I end up finding that a lot. Like you say you place them for 5,000, but I saw a lot happen for 4,000 in your system. Like there's a lot of patients that said, I won't do that for 10 grand, but I'll do it for 8. And you said yes, right? So I think there's a difference between like what I say and reality, and people aren't really looking at that from my point of view. Like I said, I'm not a dental practice owner. I just see data. So Julia, we got to wrap it up here. I was excited to have Julia Jackson on. She was instantly impressive to me. I fell in love with her pretty quick. And we've had some really good conversations. I learned a lot from you. I was an idiot the other day, and I was talking about stackable guides like it was this new revolutionary thing because I just learned about it. And Julie's like, man, we've been doing stackable guides forever. I'm like, well, thank you for keeping me from looking like a jackass because I thought they were the coolest thing. I just learned about them. I thought they were new, but apparently I just learned about them. So it's awesome having you on. Before we wrap up, Julia, what would you like to say before I wrap up with you?
I would love for your listening audience to check us out at INTLImplantinstitute.com, International Implant Institute. I think that they will see a variety of different courses. We have a webinar coming up May 21. Like I mentioned, we have live patient surgery in Cancun in July. We have chairside concierge surgery service. So I think there's a lot of resources that general dentists could utilize and work in their budget. They're not costly. Our webinar is $150 for one CE, and all the way to $20,000 to come to Cancun with us. So if you want to do all on four, take out multiple teeth, place multiple implants, hotel, transportation, and food is included with our course in Cancun. So I just want your listening audience to know that there are oral surgeons out there that are on your team and on your side and ready to help you grow, expand, and level up.
Julia, I enjoyed our conversation so much today. You're my first oral surgeon on the show in 200 episodes. You were the first one that made it through because the rest of them were really boring when I talked to them, and you're not. Like the rest of them, I was like, you're too boring for my audience. You were probably the most energetic oral surgeon speaker I've met so far. So I was excited to have you on the call or on the show. Hey, everybody, please like, subscribe, follow, share. There is no pay to play on Dental Unfiltered. We don't allow sponsorships. Julia spent $0 to be on here. She was a vetted person I spent time with who I thought would be a good subject for the show. Please leave reviews. We actually read the reviews. That is the most rewarding part of this, is hearing your feedback. Please like, share, and follow. And please, if you're looking at implant education, please check out International Implant Institute. Like I said, I was instantly impressed with Julia, and I talked to a lot of people, and she was probably the most impressive I've met so far. Thank you guys for joining us today, and have a great day.